Do. That's great. Thank you very much, Tess. I really appreciate the opportunity to be here and to speak with you. My name is Justin Lorentz. I'm a genetic counselor. I come from Toronto at the Sunnybrook Cancer Center. I also work at MedCam, which is a private healthcare facility. At the Sunnybrook Cancer Center, I lead this male oncology research education, or the MORE program. And this is a registry where we collect information on individuals who have genetic predispositions to prostate cancer, and most men that we follow have mutations in the genes BRCA1 and BRCA2. So we follow men not only on in a registry where we collect information, but also clinically to screen and manage any risks that we know of that are connected to these genes, and that's what I want to spend the bulk of this time talking about today. Good. Okay, so my agenda. I want to talk a little bit about the genes BRCA1 and BRCA2. I want to talk about prostate cancer, breast cancer, pancreatic cancer, melanoma, because these are the four cancers that we think of that are connected to this gene at this point in time. Eventually, we'll be giving a talk, and we probably already should start talking about some of the stomach cancer risk that's connected to BRCA1 and BRCA2, because as we, as a world, start testing people, we're starting to realize that maybe the initial group of people who've been had the bulk of testing aren't necessarily representative of everybody, and we might be exploring that there might be other risks, such as BRCA1 and BRCA2, that weren't otherwise on our radar, such as stomach cancer. But the evidence is still being built there, so we're not there yet. But that would be something that maybe we could talk about in a few years as we get more evidence and as we do more research on these genes. So I'm talking about male breast cancer. The first thing I'm going to pop up here is Angelina Jolie, and this is an op-ed that was generated many years ago now, where Angelina Jolie talked about her experiences having a BRCA1 gene mutation, and she chose to have both breasts removed, reconstructive surgery, have her ovaries removed to prevent cancer, because the BRCA1 gene increases risk for breast and ovarian cancer very significantly in women. And we're at Sunnybrook, we saw the rate of referrals for genetic testing increase by 100%, 50-fold, a twofold increase. And sometimes when media things pop up, we get an increase in referrals and it dipped right back down. But we had this thing called Angelina Jolie effect, where our referrals doubled and they stayed that way forever. And now they're increasing more and more. And so her talking about her experience really normalized the gene BRCA1 and BRCA2, often called BRCA. And it made this gene kind of a household name and a household topic, which is really pretty fascinating and amazing for the genetics community, because when we used to talk about genetics, we'd have to explain what genes are, and now it's pretty common knowledge. But what's not common knowledge is this other celebrity who has a genetic predisposition. He has a BRCA2 gene mutation, and he himself isn't super famous, but his daughter is. That's Beyonce Knowles, and that's Matthew Knowles, her father. Now, Beyonce and Solange did not inherit the BRCA2 gene mutation that their father has, but it's another kind of celebrity case that unfortunately did not impact referrals for men. I mention these people because there's a story here about the genes BRCA1 and BRCA2, and this is with what they're named. So BR stands for breast, CA stands for cancer, and the condition that causes or that's connected to the BRCA genes is a condition called hereditary breast and ovarian cancer syndrome. We don't hear the words prostate in there. And oftentimes when we think about the word breast, we think about breast cancer in women. And so here is Dr. King, who helped identify the genes BRCA1 and BRCA2. And there's a paper that came out a few years ago by this person. His name is Dr. Pritchard. And he kind of made an argument. He said, listen, 10 times women are 10 times more likely to get genetic testing for BRCA1 and BRCA2 than men. Could it be because we call it hereditary breast and ovarian cancer syndrome? Could it be because the gene's called the BRCA gene? And could that feel exclusionary to men? Or could it make it seem like this just impacts women? What we know is that 50% of the population has a BRCA, 50% or I guess I should say, men and women equally have the same number of BRCA gene mutations. They just impact men and women differently. And so there's lots of attention about the risks for women, but men are just as likely to have these gene mutations, although their cancer risks might not be as high. And so he kind of postulated, well, maybe we shouldn't call it hereditary breast and ovarian cancer syndrome. Maybe we should name it after the physician who was connected to its identity or to discovering them, and call it King syndrome. But calling it King syndrome in and of itself might do the opposite effect and make it seem more masculine of a condition. So there's no real winning here. But I want to bring attention to this discrepancy in testing, despite the fact that the gene doesn't care whether it lives in the body of a male or a female. In fact, it's just as likely to be in the body of a male or a female. It just manifests differently and manifests with a higher cancer rate in women. So in this presentation, you're going to see lots of bums, penises, bladders, and parts of body. And that's because a lot of these organs that are impacted by the BRCA gene live inside of us. And there's not a lot of images that we get to access these things throughout our life unless we live or work in the field of medicine. So sometimes I've made 3 people faint in my career at Sunnybrook talking about prostates and talking about screening. And so if you feel a little bit woozy about this, just look away. And I totally get that. Sometimes I'm in warm rooms and I can have a really calming voice, and it can send people in a woozy direction. But I think this is really important images to share, particularly for people who might be at elevated risk for these types of cancers. So let me talk a little bit about the prostate. Prostate is a walnut-sized organ. It lives at the base of the bladder, and when the penis goes into the body, it's also connected to the base of the penis. If you can see my mouse, it lives right here, and really it's sponge-like tissue. And the job of the prostate is to generate this chemical called PSA. It stands for prostate-specific antigen. And the purpose of PSA is to liquefy semen so that sperm can go around and do their thing. It also nourishes sperm. And it's kind of it's an important reproductive process that's there. But lots of people don't really know what it does or even where it lives. And an important thing to note about the prostate is that a lot of guys start to realize they have a prostate when they're in their 60s, because as men age, there are 3 parts of their bodies that continue to grow: their nose, their ears, and their prostates. And as your prostate increases in size, it takes up space. And based on where the prostate lives, it can interfere with the urethra, where the urine comes from the bladder out to the penis. And if it takes up space there, it causes these symptoms called lower urinary tract symptoms, like having a frequency to pee, increased urgency to pee. When someone pees, they don't have that same flow. And when people pee, they may not feel like they've fully evacuated their bladder. When men start experiencing these things, sometimes it's the first time that they say, hey, there's something going wrong here. They Google it. They start thinking about prostate cancer. They go to their doctor. They get their PSA tests. Really, this enlarging of the prostate has nothing to do with prostate cancer. It's very natural. I call it the guy's guide to being a guy. It's something that we can anticipate later on in life. There's great medications that help with this. But sometimes that's men's first kind of thought about their prostate, is when it's causing them some troubles. So this image of the prostate here, I like to focus on because it talks about the nerves that are connected to the prostate. And this is going to come up later on in the presentation. I'll make reference to this and bring this slide right back. The prostate lives here, bladder's here. And I want to note these little nerves that have the job of causing the penis to erect and also to hold in pee in the bladder. The prostate lives right in there, and these nerves are intertwined within that prostate. So it's the place for which the prostate is quite significant. And that story comes up later when it comes to treatment. So what about prostate cancer? So prostate cancer is when we get the prostate gland that has cells that divide rapidly, and people don't have symptoms of prostate cancer unless a prostate cancer is very, very late stage. You cannot tell that you have prostate cancer, and that's why we screen for prostate cancer with a blood test that I'll talk a little bit about as well. Prostate cancer is super common. 11 to 12% of men will get prostate cancer in their life. But if men have a BRCA gene mutation, those risks elevate. Now, for the purposes of the presentation, I'm going to use one site where I'm going to get my data, and that's going to be from this thing called the NCCN, National Comprehensive Cancer Network. That's based out of the US. These numbers, to me, are a little bit inflated. The BRCA1 numbers, the risk for prostate cancer in BRCA1 is up to about 26%. For BRCA2, I typically tell people it's up to 35%, but the NCCN quotes 61%. To me, it's a little bit of a high number, but again, I want to be consistent. You probably won't see numbers like this when you meet with your genetic counselor. I don't usually quote these numbers with my patients, and I don't think that NBC, these numbers are quoted as well. But I want to emphasize that the numbers for cancer risks are always a moving target. It's difficult for us to be precise as to what someone's lifetime risk is, and there's usually ranges that are provided because there's lots of data out there. And basically every center needs to make sense of the data and figure out what applies to an individual. So there's lots of variance. I want just to emphasize that BRCA2, the risk is higher for prostate cancer. So I want to talk a little bit about how we screen for prostate cancer. Prostate cancer screening is done in multiple different ways. This is called the digital rectal examination. Finger up the bum to feel the prostate, looking for any lumps or bumps. The lumps or bumps like this, these little malignant tumors here. And so the prostate's pretty rubbery, and these lumps or bumps are not, and physicians can feel that. Now, there's limitations to this physical exam called the digital rectal examination, or Dr. Dre, if that makes sense to people. I might be dating myself here. We can only palpate or feel a certain part of the prostate. Another part of the prostate remains hidden. So this digital rectal examination is by no means a perfect form of screening. However, it can fill in some gaps in other forms of screening, and we do recommend that people do this on a regular basis. This is more of an optional test. Having an increased risk for prostate cancer doesn't mean you must get this done every year. It's the recommendation, but some people don't feel comfortable to get that done, and I never want this to be a reason that someone doesn't go to the doctor. Back when there was Prostate Cancer Canada, they ran a campaign to try to normalize a digital rectal examination. And one way that men deal with uncomfortable situations is to, and this is a stereotype, but to use humor. And so kind of saying, hey, let's get these funny, famous gloves and use that as a way to do our digital rectal examinations, just to kind of help take away some of the stigma that might be connected to this form of screening. Another form of screening, and the one that everyone must do, in my opinion, if they have a genetic predisposition or any increased risk for prostate cancer, is this PSA test. And this PSA screening test looks at the level of PSA that's in the blood of an individual. So the prostate's always making this PSA. And so it stays within the prostate, but it also leaks into the blood system. And so every man every person who has a prostate has a level of PSA in their blood. And that level is really important because we want to understand what that level is, ideally when we have a young, healthy prostate, so that if there's ever deviations to that level, we can get be alerted to the fact that there might be some rapidly growing prostate cells that are generating more PSA. And the theory behind the PSA test is that if there is rapidly growing cells within the prostate, aka cancer cells, then we should see a steady increase in PSA value. And that can alert a doctor to then say, I think that there's something going on here, even though you feel perfectly fine. Let's do a diagnostic test to see if there is any cancer within your prostate. So this might be the sign that people use to suggest that there might be prostate cancer. Now, PSA is important in the value of the PSA increases with the amount of times that you do it. And so consistency is key with this test. We'd like people to get this done every year to establish what's called a baseline level of their PSA. Their PSA is always kind of go up and down and up and down, and that's very fluid. PSA level in a man will vary a little bit throughout the day. And so we want to just get as many time plots as we can so we can understand what a man's average is. Ideally, we do this in their 40s and 50s so that when they're in their 60s and 70s, we have that data to compare to. The PSA can be finicky. Rapidly growing cells in the prostate, cancerous cells, increase PSA, but a bunch of other things increase PSA too. So I like to talk about PSA optimization for men who need these PSA scores to be done well. As the prostate grows, it creates more prostate cells and PSA levels naturally rise. This is through the prostate getting bigger, and we can see this through PSAs. PSAs will gradually increase over time, which is fine. It's just they increase steeply, we get concerned. Prostatitis is inflammation of the prostate. This can also cause PSA to increase, and it can freak men out because they have a PSA test, and then one year it really skyrockets, and they think, "Oh my God, is this cancer?" And the urologist or the physician's like, "No, this is fine. Maybe we'll put you on antibiotics, and we'll just repeat this in 2 months because you might just have an infection." Infections of the prostate can cause no symptoms. They can cause night sweats. They can cause flu-like symptoms. They can cause pain. People have no symptoms or night sweats. They might have no idea that they're getting this and do a PSA test. And a PSA test might be really, really high, and it will go right back down. Prostate cancer can elevate PSA. A recent ejaculation, when there's an ejaculation, the prostate sponge-like tissue squeezes, all the PSA comes out of it to do its job. But the PSA then goes into the blood as well. And so we'd like people to refrain from any prostate stimulation. The most common thing that we think about is an ejaculation, but it could be anything, including a digital rectal examination or anal intercourse, anything that would stimulate the prostate. We like people not to do 24 hours prior to getting a PSA test. Digital rectal examination is prostate stimulation. You're poking at it. That can increase more PSA. So we like people to do a PSA before they do a digital rectal examination. Based on the logistics, where you sit on a bike, your prostate's like right here. So if you hit a bump, boom, it can also jiggle the sponge-like prostate and falsely release PSA. So don't bike to your PSA test, and don't bike any bit 24 to 48 hours prior to your PSA test, or do a riding lawnmower or a motorcycle. They'll have the same effect. This optimizes how we do a PSA. Now, PSA is high. What happens next? There's a biopsy, and the biopsies are done transrectally. So they put a little device through the prostate. They numb the prostate, and they take little biopsies, little cores, little pieces of the prostate. They basically divide the prostate up into like 12 sections, like hours on the clock, and they just try to sample that region, and then they analyze the tissue that's picked up from that. These prostate biopsies, very commonly done procedures, very, very low risks. It looks uncomfortable. It is a little bit uncomfortable. Men typically don't report pain. They report an electric shock-like sensation when those cores are being removed. But very commonly done, and lots of men will get multiple of these throughout their life if their prostate is generating more PSA. That's concerning. When that prostate core gets received, they give it off to a doctor who will review that under the microscope. They're basically looking to see what the cells of the prostate look like. If they look really nice and clean and uniform, then that's a low grade or low chance that there's cancer. But if they get more odd looking, then they get a different grade showing that there might be concern for cancer. And they classify these grades of cells into Gleason scores. That was back in the day. Nowadays, they're using the word grade groups. And the reason for that is because if you tell someone they have Gleason 6 prostate cancer, that's the lowest grade prostate cancer. That's excellent, really, really low risk prostate cancer. But the individual is thinking, hey, that's 6 out of 10. Low for me is 1. And so the number score that we use through psychosocial studies, we realize could have an impact on people's perceived risk. And so we've changed it to the grade group system to reflect that. Yeah, you're grade 1, you're low. And grade 5, or Gleason score 9 and 10 is the high grade. So you might get either a Gleason score or a grade group to define your prostate cancer if that's part of your life story. When it comes to prostate cancer treatment, there's multiple modes of treatment. The first one for people who have low-grade prostate cancer is something called active surveillance, where there actually is no real treatment. It's basically a monitoring. And that's going to be through periodic PSAs, through the physical exams, DREs. The doctor that I work with, he calls them to, again, use humor to dissolve a potentially awkward situation, MRI scans and repeat biopsies. If men do this over time, sometimes their prostate cancer after a biopsy, maybe 5 years in the future, shows that the prostate cancer has progressed. And then they move on to another form of treatment, which is, kind of picking your poison. This is maybe dating myself again, looking at the Matrix. We have Morpheus here, who's going to give the option of the red pill or the blue pill. But either way, both treatment options are not ideal, but certain people have different kind of ways of looking at it, and they have debates with their treating physician to say, hey, which way do I want to go down? What's most comfortable for me? And the first option is to have the prostate removed, either through robots or hand surgery. And the other way is to have radiation, either through seeds that are implanted within the prostate or using radiation that just targets the prostate from outside the body. The seeds are in the prostate from inside the body. The ways that which we do the removal of the prostate, the prostatectomy and radiation, the technology is changing, every year, particularly in the radiation world. And side effects are getting better and better from this, but I do want to focus on the side effects. So when prostate cancer is treated, I get back to this nerve slide, where if you remove this prostate, you could tamper with these nerves that are associated with erections, that are associated with holding in pee. We call that urinary incontinence. And the degrees with which these two processes are impacted can vary from an individual, to that, an erection may never be the same, to needing a lot of assistance to get maintain an erection. Alternatively, when it comes to bladder control, there could be maybe very mild issues with bladder control, to some men being dependent upon a catheter. So knowing the risks is a good conversation, and talking about what the risks are for your demographic, for whatever health factors you have going on, for your age. The person who's doing a surgery will be able to give you insight, or doing radiation will be able to give you insight into what outcomes can be like. These are very frank, open, and good conversations to have. And then after these surgeries, there's a whole bunch of amazing resources that are available to help with rehabilitation after treatment. Another form of treatment is if the prostate cancer is maybe a little bit more aggressive and has spread to other parts of the body. We can look at using hormones to decrease the rate of progression of prostate cancer. Testosterone helps drive prostate cancer, particularly in its earlier stages. So if we cut off the testosterone, we call that castration. And it's a chemical castration through the use of removing the hormones. This can either stop prostate cancer in its tracks, and it could do this for many, many years. Being on hormone treatment can impact and has its own side effects that are connected to it, but it's a very effective way to treat prostate cancer. As a last option, we have prostate cancer treatment through chemotherapy, and this is an individual who has a port that's put into his chest, in which you can give chemotherapy. Now, in the context of BRCA1 and BRCA2, the story is a little bit different when it comes to treatment, because we have treatments that target and kill cancers that use the BRCA or that have BRCA mutations. And it's through a process called synthetic lethality, which is a jargony term. But essentially, what the BRCA genes do is their job is to protect from cancer. And how they do this is by repairing DNA. And the main pathway that they use to repair DNA is it's called the HRR, or homologous recombination repair. We'll call it the HRR pathway. And in this diagram, it's the pathway that's shown off in the orange. But the second way that DNA can be repaired is through the BER, or base excision repair pathway, or the PARP pathway. So if people have these inherited genetic mutations in BRCA1 and BRCA2, their DNA repair way through HRR is compromised already because of the genetic mutation. And so these cancer cells are dependent upon the second pathway, the BER pathway, because if they do not have any way of repairing DNA, even cancer cells can't survive that situation. And so the scientists said, hey, listen, these cells already have one pathway eliminated. If we can create a drug that eliminates the second pathway, then these cancer cells have no shot. They have no way of repairing DNA. That should really be impacting them. And that's what they did. And so for people who have these BRCA gene mutations, they give them a medication that blocks one repair pathway, and their cancer already has a block in the second pathway. And now this cancer cell says, I have no way to repair DNA. I have to synthetically kill myself, lethality. And so the cancer cell then says, game over. I can no longer exist. And so that's the pathway and the mechanism for which these medications work, and they're applicable to people with BRCA gene mutations. And it's kind of our definition of precision medicine. One thing I want to note is that BRCA1 and BRCA2 increase risk for prostate cancer, but people with BRCA2 gene mutations, we know that their prostate cancer will become a little bit more aggressive than prostate cancer in the general population. General population, the stereotype about prostate cancer is that men die with prostate cancer because we have all these amazing treatments. Most men do not die because of prostate cancer. Back in the day when we were studying BRCA2, we noticed that that was actually not the case. Men with BRCA2 mutations were dying because of their prostate cancer. And it was because it wasn't really on our radar at that time. And so all of this old data that we have shows how aggressive BRCA2 prostate cancer can be. But nowadays, men who have BRCA2 gene mutations are getting screening. They're getting prostate cancer picked up early if it's part of their life story at all, and they're getting great treatment. And so the data we needed back in the day to show how prostate cancer reacted in BRCA2 carriers, but we're not seeing that same thing anymore because we're able to pick up these prostate cancers earlier. And it would be, unethical not to treat people with prostate cancer with BRCA2. So we shouldn't see that trend unless people present with aggressive prostate cancer and then realize they have BRCA2 gene mutations. So I want to switch gears away from the prostate story and move into the other risks that are connected to BRCA1 and BRCA2. And this next one's breast tissue. So when we think about breast tissue, a lot of through my kind of personal experience working in the clinic for over 10 years, a lot of men say, hey, I didn't even know I had breast tissue. But all humans do. It's just that breast tissue acts very differently depending upon the body that it's in. If breast tissue is in a body that has hormones that are like androgens, these are hormones like testosterone. If it's a testosterone dominant world that the breast tissue is living in, it's not going to do too much. It's going to not grow. It's going to stay very naive and similar to how it's not going to grow or develop or do too much. However, if breast tissue is in an environment that's estrogen dominant, it will do a lot. It will grow, it will change, it will diversify. And so a lot of men throughout their lives are in a testosterone dominant or their breast tissue is in a testosterone dominant environment. This changes though. As men age, sometimes the shift in hormones differ, and we'll talk a little bit about this. But the kind of typical way that a male chest looks when you kind of looked at it on the side, we have the ribs, we have muscle tissue, we have fat tissue. Then at the nipple, the areola, which is the brown spot around the nipple, and the ducts. That's where most of our of breast tissue is for men. There's this thing called gynecomastia. Gynecomastia is a term that we've given to show when men develop more breast tissue. And you can see that there's this growth in the chest. And a lot of men, as we age, develop gynecomastia because there is a hormone difference and because that tissue, the dominance of the testosterone can switch later on in life. And when men develop gynecomastia, they get this dense tissue called a mammary pad. And it can be the size of a dime to a toonie, it can get bigger. And that's a very natural part of human existence. This slide kind of nicely compares what breast tissue looks like in an estrogen dominant environment. That's female breast tissue. And the breast tissue will diversify, become ducts and lobules, These are to generate milk in the lobules do, and then the ducts bring the milk to the nipple. In male breast tissue that's in a testosterone-driven environment, we get very little development. And then in breast tissue that has maybe some estrogen to it, we get this gynecomastia where there's that mammary plaque. There's two different types of gynecomastia. One gynecomastia is when there is glandular breast tissue, these mammary pads, and that's due to a higher estrogen environment. You can feel a difference. It's kind of like a more dense tissue that's under the nipple or the areola, and it's a hormone imbalance. But then there's also this thing called pseudogynecomastia. And pseudogynecomastia is when there's excess adipose tissue or fat tissue. And so it can look like a gynecomastia, but when you feel it, there isn't that mammary pad. It's just fat tissue. One thing about this, though, is that if someone has enough fat tissue actually releases some estrogen on its own. And so people can then develop real gynecomastia after having pseudogynecomastia. So there's this interlay between these terms that's important to think about when it comes to this. The part about the enzymes in the fat tissue that create some estrogen as well. So what are risks for breast cancer? I guess even before I go here, gynecomastia, we don't think that this is actually increasing risk for breast cancer too much. There's one group of people who have a genetic predisposition to get more gynecomastia than other individuals. These are individuals with Klinefelter syndrome. We see a little bit of an elevated risk for breast cancer, but gynecomastia in and of itself is not thought to be a risk predictor for breast cancer, particularly in the BRCA population, based on what we know today. So general population risk is like 1 in 1,000 to get male breast cancer. For individuals with BRCA gene mutations, it ends up being 1%. And so a greatly increased risk, but still very low risk compared to the general population, or very low risk in the context of lifetime risk. For BRCA2, we can see about a 7% lifetime risk. And that approaches the general population risk for females, which is 11 to 12%. And so for individuals with BRCA2 who have breast tissue that's in a testosterone-driven world, so men with BRCA2 gene mutations, the lifetime risk getting breast cancer is 7%, or the other way of looking at it is the risk of not getting breast cancer is 93%. Most men don't get breast cancer if they have BRCA2 gene mutations. But there are some important things to kind of think about and look for. And screening for breast cancer is not nearly as complex as it is for prostate cancer. It's quite easy. And the way that you're managed afterwards is quite different than the general population if any of these things pop up. And so breast cancer isn't connected with pain. It's a lump or a bump. That's usually around the nipple, the areola, the chest, or the armpit. And the reason why is because there's these lymph nodes that cancer can hang out in as well. And so if anybody with a BRCA2 or BRCA1 gene mutation has lumps or bumps, chest, armpit, nipple, areola, if there's dimpling where tissue kind of goes into the body a little bit, redness, scaling, rash, changes in the size of the chest or the breast. When it comes to the nipple, if the nipple's ever inverted, the nipple's usually kind of pops out. If it pops in, that's a big indicator to think about going to your doctor. If there's a discharge that comes out of the nipple, big indicator to go to your doctor. And if you present with any of these symptoms, your doctor will say to you, let's get some imaging done. Let's do a biopsy of this area. If I, without a BRCA gene mutation, came to my doctor with these symptoms, they'd say, maybe 6 months, let's come back and see how things are going. Because the low thing on their differential is breast cancer for someone without a gene mutation. But someone with a gene mutation, the first thing on every doctor's mind should be that, and they should be treating you like there should be a workup for something like breast cancer. Like I said before, I wanted to reference the NCCN guidelines about what we're doing with breast cancer screening. I went back to 2021, and what we were saying is that we should be doing breast examinations starting at 35. We typically say starting at 40. A clinical breast examination by a family doctor or a specialist starting at age 40, and then consider annual mammograms for men with gynecomastia starting at age 50 or 10 years before the earliest case of male breast cancer. Fast forward to now, as of last month, the gynecomastia piece is no longer part of the recommendations. We've learned enough to think that we don't think gynecomastia is connected with elevated risk. Instead, we would consider doing these mammograms only just in men with BRCA2 gene mutations. And that could start at age 50. But in our clinic, we don't even do annual mammograms. We would start doing those kind of at the patient's comfort, but maybe every other year. And it's really the Wild West in terms of how we manage individuals. But we do clinical breast examinations starting at age 40, not 35. And we teach people how to do their own self-examinations so that they're in control and can know what to look for and how to look for it. And family doctors can teach you how to do your own breast examinations. Okay, next tissue I want to talk about when it comes to BRCA is the pancreas. And so the pancreas is an organ that's right inside of our body. It's difficult to image, just like ovaries are difficult to image, mostly because it's a pretty cystic, tissue. And so cancer looks kind of cystic too. And so the imaging that we use, ultrasounds, MRIs, isn't really good at picking up cancer within this tissue. And so we don't have any good way of screening for this, as we'll talk about a little bit earlier. But what does the pancreas even do? So its job is to create enzymes that help us break down foods, particularly fatty foods and meats, things with fat and protein. But it's also associated with some hormones, particularly with regulation of sugars, and helps with how we break down glucose and its role in preventing things like diabetes and its use of insulin. For individuals with BRCA1 and BRCA2 gene mutations, we've seen elevated risk for specific for pancreatic cancer, depending upon whether it's a BRCA1 or BRCA2 gene. Again, most individuals with BRCA gene mutations do not get pancreatic cancer. 90 to 95% of people will not get pancreatic cancer. However, if there's a family history of pancreatic cancer and someone has a gene mutation, it's a little bit more on my radar. The difficult thing with pancreatic cancer is that there's no good screening tool that's available to identify pancreatic cancer early. All of the imaging that we have done, all the studies that have done imaging have never proven to do what screening has meant to do, which is pick up cancer early. Screening can pick up cancer, but it can pick up cancer late. And that's no longer a screening tool if it's identifying cancer late. So we still do not have any good way of identifying pancreatic cancer, which is a challenge. And it's one of the kind of non-actionable findings that we can get with this BRCA1 or BRCA2. And it's kind of a point that the research world has been trying really hard to get some kind of a screening technology for so long. And there's just been so many misses. But it's top of mind for so many different organizations. One thing that pops up a lot, and I've heard a lot from my colleagues and then also from patients, is these blood tests that are called MCED, or multi-cancer early detection tests. And how they work is by having someone provide a blood sample, and cancers are essentially our own cells that have gone rogue. They are dividing uncontrollably. They're taking resources. But when cancer cells die, it's our bodies that deal with these cancer cells. And so the dead cancer cells and the DNA that sheds from these dead cancer cells is floating around in the bodies of patients who have cancer. And so this test is able to identify in a blood sample whether or not there's DNA that looks like it's cancerous. And even further to that, there are, I say it's through AI, but really but this was before, I think, the AI story. There's different markers or patterns that we can see within the DNA that can suggest this came from melanoma, this came from pancreas, this came from prostate cancer. And so the technology is to be able to identify in the blood system, is there cancerous DNA? And if so, where is it from? The issue with this is that it's not validated yet. The theory is there, the concept is there, the technology is there, but the execution still is not at the level where it's useful clinically. And we're keeping our fingers crossed that this does get the studies are able to prove that there is going to be clinical validity to it. But I tell people these scenarios, and I've had somebody come to our clinic who had a test like this done that said, "Hey, I screened for prostate uh, um, cancer DNA in my blood. I did a test like this and screened positive. He has a BRCA2 gene mutation." The physician I work with, Dr. Danny Vesperini, and I were pretty concerned. We did a PSA test. His PSA looked great, but we went on and did an MRI of his prostate, and his prostate MRI was perfect as well. He opted not to do a biopsy, but we ended up doing PSAs, MRIs, and offered a biopsy to this guy who has no concerns for prostate cancer aside from this test. And the test was wrong. The issue with these tests is that I don't know how right they are. I don't know how wrong they are. And it leaves the clinician to have to do all these investigative, processes. And if it's wrong, it just caused this person, this person was crying in our office for every appointment that he had, so concerned about his prostate cancer risk, and rightfully so. But this stuff is still relatively, if not unregulated by certain companies, it's definitely not FDA approved. And until we can get the data to find out how useful this is, how correct it is, we like people not to use it. It is available in the US, but we advise people not to do it. And there's two basic scenarios I like to offer to people to tell people this exists, but that we're still in the research development stages of this technology. The first is you do this test. The test shows there's melanoma DNA floating around in your blood. You go see a dermatologist. The dermatologist does a full examination and says, "You look great." How do you marry those two concepts? Who's more right, the doctor or the test? And are you comfortable leaving that doctor's office without any treatment, knowing that there might be some risk in your blood, and not knowing how wrong that test is? We need to be able to understand those scenarios better before we can offer this test responsibly. The second scenario is with pancreatic cancer. Same thing. We see pancreatic cancer floating around in your blood by this test. We don't know how right it is, but then what's our diagnostic procedure? Doing a biopsy of the pancreas is incredibly invasive. There's no good way to image the pancreas. Some people may opt to have their pancreas removed, which is a Whipple surgery, as the treatment, hugely impacting quality of life. An incredibly difficult procedure to do. People are in the hospital for a week afterwards. And if someone did that based on a screening test like this, and the pancreas was perfectly fine, is there litigation-related issues that are related to this? So we really need to be able to be confident in how well these blood screening tests work before we start employing them. And Canada will not be doing this. And if people are doing this, it's in a completely unregulated world. And so I advise people to avoid this at this point in time. However, I do want to say that between this test or a urine test in the next 5 years to 10 years, I expect there to be a good way to screen for pancreatic cancer. I think this is the right direction. It's just not the right test at this time. Treatment for pancreatic cancer is that Whipple. The other one is also these medications called PARP inhibitors that use this concept of synthetic lethality, just like they do with prostate cancer. The last thing I want to touch on, as we're getting close to time, is risk for melanoma. So the NCCN does not provide lifetime risks for melanoma anymore. The reason for this being is because we used to think there was a really strong connection to melanoma, and over the years of doing research, we're realizing this is less something that we need to worry about, particularly in people with BRCA1 gene mutations. Individuals with BRCA2 gene mutations, there might be a little bit of an elevated risk, but this data is amongst individuals who are white, come from European ancestry, and may be more fair-skinned. There might be a bias in some of the data that we have. However, because there is still a lingering old data to show that an increased melanoma risk, if people have skin findings, they get maybe taken a little bit more seriously by dermatologists if they have BRCA2 gene mutations. But currently, there's not that many dermatologists who are annually screening or following people with BRCA2 gene mutations. Instead, they're saying, hey, if you have a suspicious change, or if by following the A, B, C, D, E rules of a mole, and you're finding that there's asymmetry, that there is an irregular border to a mole, there's differences in color, it's getting bigger. These are reasons to tell your doctor, hey, there's a change, and then your doctor is more likely to want to refer you to dermatology given your BRCA2 status. I don't know what the lifetime risk is for melanoma in individuals with BRCA2. It may be elevated, but there's lots of factors that might be connected to why that are difficult to predict for an individual. And so if someone has lots of moles, they can talk to their doctor about seeing a dermatologist, but the dermatologist is going to say, what do you want me to look at? Not, let's do a full body scan. And so there's going to be a little more direction with that. When it comes to melanoma, I mean, in BC, sun exposure might not be the biggest issue in the world. But when there is sun exposure, trying to wear an SPF, wear sunglasses, have wide brim hats, covered up, seek shade. One of the things about SPF is that there's like SPF 50, SPF 30. People say, like, isn't SPF 30 just the max? Why do they have 50? One of these things is that there's lots of errors in how humans apply SPF. And so sometimes there's an SPF 50 because they know that people aren't going to do a good job in applying it. And so they have this higher SPF to account for that. If people are really great at applying sunscreen on a regular basis, they may not need as much of it. But these are great things to talk with your dermatologist about. Under zero circumstances should anybody with a BRCA gene mutation or anybody at all be using tanning beds. The sun is not generally our friend, particularly if we want to have these young, fresh faces. UV exposure is something that doesn't keep us looking young and fresh over time. So things to kind of consider there. Okay, so I went through the cancer risks that are connected to the BRCA gene mutations, pretty in detail in certain aspects, but there might be some gaps in what I'm talking about. If people have any specific questions related to themselves, family members, or in general concepts, I'm happy to go into it. I guess I will say one thing. If there's a question that's super specific, maybe it wouldn't be best for us to share with everybody. You could always, maybe if you wanted, message me indirectly, or you can message me personally, and I can leave my email address in the link in the chat for you to contact me specifically. If you have some questions that work for everybody, I'm happy to hear them.